Good evening, everyone, and welcome to tonight's American Migraine Foundation webinar, which we are calling Navigating the Intersection of Menarche, Hormonal Contraception, and Migraine, Insights and Strategies. My name is Dr. Claire Sando. I'm a neurologist and headache specialist in Toronto, as well as co-chair of the AMF editorial board, and I'm joined by two great panelists tonight, Drs. Kate Stika and Jelena Pavlovich. I'm going to introduce both of them. We'll talk a little bit about what you can hopefully expect to learn from tonight, and then we'll kick things off. So first, Dr. Kate Stika, who is a clinical professor of obstetrics and gynecology at Northwestern University. She has done amazing things in her field, as well as with some crossover into the headache field. She was the first director of Northwestern's OB triage for many years, where she frequently treated pregnant patients with migraine and other types of headache disorders. She's lead author for the clinical practice guideline from the American College of Obstetrics and Gynecology on headache in pregnancy and postpartum, and is their liaison to the American Headache Society. So we're really looking forward to her cross-disciplinary expertise. And our other panelist tonight, Dr. Jelena Pavlovich, is an associate professor of neurology at Albert Einstein College of Medicine and an attending neurologist at Montefiore Headache Center in New York. She also has a PhD in molecular biology from Penn State College of Medicine, and she has done very extensive, very interesting research on migraine in women, but funded by the National Institutes of Health. And she's been recognized with awards, including the Women's Health Science Award from the American Headache Society. And she's a powerful advocate for women's issues in headache. So I'm looking forward to learning from both of our panelists tonight. We are going to talk through, in general, the impact of hormone changes on migraine and some treatment considerations with a specific focus on menarche. And just for our audience tonight, this is the first of a planned series on women's health. We're going to have a few more webinars later this year, specifically on things like fertility treatments and menopause. So some of those topics won't necessarily be covered in as much detail tonight. And please do feel free to submit your questions as we go along using the Q&A function. We'll be trying to leave 15 minutes at the end to answer as many of those as we can. So to get us started, we're just going to start by generally trying to set the framework of what is happening. And so I'm going to ask Dr. Stika to tell us a little bit about the kinds of hormone changes that happen in puberty and what this has to do with migraine.
So to talk about puberty, I think it sometimes makes more sense to talk about what happens in a woman's menstrual cycle when she's fully menstruating and having a period once a month. And what occurs is this dance between your brain, your ovaries, and your uterus. And people know that once a month when you have your period, and when you don't get pregnant, your uterus bleeds and that lining is sloughed. Well, that lining is built up during the month before because of the hormones that your ovary makes. And your ovary knows how to make those hormones because of signals that come from your brain, go through your blood, and go to the ovary. And what happens is there's a control mechanism between the brain and the ovary. So when your ovarian hormones, estrogen and progesterone, are low, the brain sends a signal to say, turn on, find those eggs, start developing eggs, and around that egg, it makes estrogen and progesterone. And as those levels climb and get higher, it feeds back to the brain and it turns off those signals so that your body is able to regulate. The brain tells your ovaries to make hormones. Your hormones tell your brain that you've got enough and you can turn off that signal. Well, you bleed because the estrogen builds up the endometrial lining, the lining of your uterus. And then when you ovulate, when you release that egg, that area around where that egg came from also makes progesterone. And that changes the lining of your uterus and makes it ready to get pregnant. If you don't get pregnant, the ovary has lost its signal from the brain. It stops making those hormones, and those hormone concentrations fall. The lining in your uterus no longer has the support coming from the ovary, and it sloughs, and that's your menstrual period. And then as those hormone levels fall when you don't get pregnant, the brain says, wait a second, where are those hormones? It sends signals back to the ovary to start finding another egg, to recruit another egg, to build up those hormones, and the cycle starts all over again. So in terms of migraine, there are two different periods where women tend to get migraines around her because of the changes in hormones. One of them occurs when, if you don't get pregnant and the hormone levels fall, the estrogen, the estradiol, and the progesterone both fall. And it's the fall in the estrogen that makes the brain unstable in terms of migraines. Or it's, and Yelena will talk a lot more maybe about how it affects the brain, because, but the estrogen levels fall just before you get your period. There's another time that estrogen levels fall. The brain is sending signals, FSH, to the ovary to recruit, to find follicles, the early, eggs that are ready to develop. And it starts catching, and a bunch of them respond. Only one of them finally ovulates, unless you have twins, in which sometimes two of them ovulate, but only one of them ovulates. But all those other follicles that have been making estrogen, they die when that one ovulates. And so you have this rise in estrogen, but when then you lose some of those follicles, the estrogen levels fall a little bit right at ovulation. So you see a little bit of a fall right at ovulation and a big fall right around your period. And it's those two different times in the cycle when the estrogen levels are falling that the brain can feel the effects of the loss of estrogen. Does that answer the question? Is that?
Beautifully answers the question. And so maybe Dr. Pavlovich, you can tell us more about what all of these dancing hormones mean for migraine, especially for adolescent girls and around menarche. And you're muted.
Absolutely. Hi, sorry about that. Thank you, Dr. Sandel, for the introduction, and Dr. Stika for that great explanation on very complex really reproductive endocrinology, right? And for those of you who are thinking this is complicated, this is complicated. And this is complicated for everyone. This is one of the things that are hard to learn and memorize in medical school. And Dr. Stika and it's very hard to explain as well, because there are many mechanisms happening simultaneously. But from a specific neurologic perspective, as that is my perspective, and that is the field that primarily treats migraine, though I think this webinar argues and we aim to actually treat migraine in women, especially in an integrated way. As I'm sure many among you who have migraine or have loved ones with migraine have found that it really takes multiple teams of doctors rather than just one doctor to treat complex migraine effectively. And that is because migraine is not only a hormonal state, it is not only a brain state. It is really, I think, helpful to see it as a brain state that is specifically influenced by hormonal fluctuations and hormonal changes. And we see that because so many women describe association of the occurrence of their headaches, their migraine headaches, with their hormonal fluctuations that Dr. Stika was talking about. And we've known since the ancient times, there are all kinds of stories that support this association of migraine with hormonal fluctuations in women. Hormonal fluctuations in women, as Dr. Stika said, primarily being related in practical terms to either menstruation, right, having a period and what occurs right before and around the period. And then other hormonal fluctuations in women that are not on that monthly timeline, but on a timeline of a life's development, right? So we know that in menarche, in puberty, there are major hormonal changes happening. There's clear physical manifestations of them with, adolescent, those who have been adolescent girls have gone through them or seen adolescent girls undergo tremendous physical changes. And at that time, also time of menarche often overlaps with first occurrence of migraine. In fact, about 1/3 of women who have migraine had their first onset of migraine at the time of their first menstrual period. So we'll talk more about how specifically these hormonal changes affected, but to put it broadly, we believe that this brain state that is believed to be genetically regulated and genetically predisposed in women is then additionally regulated by hormonal fluctuations and onset of menarche, which is a major first kind of hormonal fluctuation that happens that the brain sees. And this actually leads then to some control of migraine and occurrence of migraine in women. And as I was saying, on the terms of the span of life, adolescence being an important time in young girls, then later on during menstruation, right, regularly occurring. And then in times of pregnancy, when hormones are stable, we tend to see stabilization of migraine occurrence. Also in lactation, depending on breastfeeding, it can lead also to decrease occurrence of migraine because of stabilization of ovarian hormones. And finally, in a topic that will be in detail addressed at one of the next webinars, during perimenopause, when there's tremendous fluctuation in ovarian hormones, we see a lot of fluctuation and occurrence, potentially increased occurrence of migraine headaches in those who already have migraine. And finally, generally with menopause, we see kind of abatement and senescence, the quieting down of a headache occurrence in those who have had migraine often. And this provides relief for women with migraine. Does that answer the question?
Just to add a little bit more about the childhood and why the first menstrual period is so important is because the ovary and the pituitary gland are pretty much turned off in childhood, and gradually as a girl approaches puberty, as approaches adolescence, and the average age in the United States is somewhere around 12, late 11s, early 12 years old, but the estrogen levels are beginning to increase, and the brain is sending more and more signals to the ovary, and the estrogen levels are beginning to rise, and that's beginning to cause all those other changes that you see in terms of breast development, and all the other changes associated with adolescence, but you don't see falls in the estrogen. It's just a gradual rise, and it really isn't until you begin to have menstrual periods, which oftentimes are very irregular and erratic in when girls first start having them. But that's when you see the first falls, and that's why you see the first onset, the predisposition of migraines, that occur more often in girls because of those repetitive falls in estrogen that are caused by her menstrual cycle changes.
Exactly. Yes, exactly. And if I can just expand on that, I mean, we see that in headache epidemiology, in migraine epidemiology, because before puberty, migraine prevalence is relatively equal between boys and girls. In fact, actually, boys in early childhood, age 6, 7, boys are more likely to have migraine than girls. And then after menarche, after the occurrence of the first period, and by late adolescence, we see girls developing migraine and reaching by late adolescence prevalence of migraine that we is seen in adult women, which really in reproductive age women, about 25 to almost 30% of women can experience migraine onset, which is really speaks to incredible impact of this condition on society at large. And, a segue, but why is this so important? Because this is a disorder that really affects girls and women during a very, very stressful in terms of what is asked of them, in terms of development, in terms of advancing one's life and taking care of family and work and their cells during very potentially stressful years of life when they're expected to be healthy and perform at the highest order that they can. And yet this is a chronic disorder with episodic manifestations that is often silent, right? And we are not focusing our conversation on that today, but I think it's an important message for our patients that the aim of all of this is to kind of to tell you that we see you, that we know that this occurs, and that the burden of migraine, especially hormonally related migraine, is very real.
Thank you for that, Dr. Pavlich. That was really beautifully said. And I want to support that. I think it's it's very helpful, this idea that if you have migraine all the time, whether you see it or not, whether you have an attack or don't. And so all of those changes, internal, external, are so powerful, and it's easy for people to understand. Maybe they're dehydrated. That could be a problem. Hormones are changing. This could be a problem. Those internal and external things are, I think, helpful to keep in mind, and that's not somebody's fault that that's what's happening to their body just because they are female. So thank you for that. Maybe we'll switch gears a little bit and try to put into the mix now some of the hormone things that we do. And so Dr. Stika, can you tell us a little bit about some of the hormonal kinds of manipulation contraceptives that we use and how they work?
Sure. So the concept behind hormonal contraception is that the stimulation from the brain to the ovary develops a follicle, an egg that becomes the oocyte, the egg that gets fertilized. And that happens every month. And what you want to do, I mean, there's multiple different ways of preventing pregnancy. I mean, one easy way is just say, no, you don't have intercourse. That's not realistic. So then you have to figure out, how do you keep the sperm away from the egg? Because if you happen to have, sex right at the time of ovulation, upwards of 25% or more of people will conceive based on that one occurrence. So you can block the sperm from getting there and use condoms, barrier methods. One of the most common ways is preventing the egg from developing. So how can that happen? Well, what you have to do is you have to turn off the brain. You have to turn off the stimulation that's coming from the brain to that ovary. And the easiest way to do that is, just as I explained before, the brain reads the levels of hormones in your body. And when they're low, it sends signals to the ovary. But when they're higher, it turns off the brain and those signals stop. So by giving either estrogen or progesterone, or a combination of them, and having them in what we call pharmacological levels and constant levels, that turns off that stimulation to the brain, and it just goes quiet. And so long as you're taking those hormones, the brain is quiet. And then when you stop them, the brain wakes up again. Literally, it wakes up. It takes a while for it to wake up, and it starts that dance all over again. So how can we give those hormones? How can we administer them? Probably the most common way is taking a pill. And it started when the pills were first developed back in the 60s. They knew the safest of the estrogen and the progesterones were progesterone. So they developed a pill that was predominantly progesterone to use as a birth control pill. Well, it turned out that their chemistry back then wasn't so good. And they couldn't make a pure progesterone pill. They were making them from yams in Mexico, believe it or not. The steroids that were in Mexican yams was the compound that they were using to make contraceptive hormones. And what they found is, when you gave people the more of that mistaken estrogen that was there, the less problematic was the breakthrough bleeding. I don't know if anybody out in the audience has been on birth control pills or any other form of hormonal contraception. One of the common nuisance problems is that your uterus kind of sometimes bleeds ever so often. It's not like quiet and then menstrual period and then quiet. It can have breakthrough bleeding. And so they started adding estrogen to the pills. And so for the longest time, the most common form of birth control pills was a mixture of estrogen and progesterone. We have over time tried to find out progestins that work better, that have fewer side effects, because some of the side effects of the progestin pills are that they also affect the male androgen. They act like male androgens, and you can get acne and other problems related to that people don't like. The estrogen, we found out that the higher the concentrations, the greater the risk of having blood clots and stroke and heart attack and blood clots in your legs, and people dying of blood clots in their lungs as well as to their brain. And so we've over time reduced the amount of estrogen that we give. So now there's a whole slew of different types of pills available with both estrogen and progestin, with various amounts of estrogen in them. because different people work better with different amounts of estrogen, with various types of progestins, because there are a whole different types of side effects. We've also then, so that's your combination estrogen and progesterone, pills that we take. We also have a progestin-only pill, and those have evolved. And the current one that's on the market, which is probably the better one, which is called the generic is, the trade name is Slind. The generic is drospirenone. That is a pill that you can take every single day. It's much better than the older ones where you absolutely had to take it every single day. And if you were like 6 hours off, you'd have breakthrough bleeding, you might get pregnant. And it wasn't a very good progestin-only pill. But the current one, the drospirenone, is a very effective, excellent progestin-only pill. You can also get hormones in different ways. You can have a progestin implant that's called Nexplanon, where they put a little rod under the skin in your arm, and it releases hormones very slowly, but in a high enough concentration of etonogestrel that it turns off the brain. And that's good for 3 years. There are also patches. There are 2 different patches on the market, which is much better than the older one. The one that we commonly use as a patch that contains both an estrogen and a progestin is something called Twirla. And that's a patch that you have on, you leave it on, you apply it on your stomach, on your hip, on your butt, someplace that doesn't show, and you put it on for 3 weeks and you take it off for a week. There's also another way of giving it, and that's estrogen and progestin in your vagina. And it's a ring, and there's 2 different types of rings. There's a ring that you can put in for 3 weeks and take it out and then put a new one in. And it has both an estrogen and a progestin. And there's a brand new one that's called Anovera that's got a really special novel progestin in it. It's both estrogen and progestin. And that one actually lasts a year. And you can take it out whenever you want to get your period. And then you just put the thing back in and it will last for a whole year. The beauty of hormonal delivery, the way that your body sees the hormones when it comes through either the skin or through your vagina or from an implant, is that the concentrations are really steady. They don't fluctuate, they don't go up and down, as opposed to taking a pill, because every time you take a pill, it goes up and it comes down, it goes up and it comes down, it goes up and it comes down. And each time it comes down, your brain is seeing that fall, and that can sometimes predispose people to seeing those fluctuations in estrogen. The other thing is, when you take it through the skin or through the vagina or the implant or an injection for like Depo-Provera, what your brain sees in terms of turning it off is the same thing that your liver sees. And many of these hormones, one of the biggest complications is that it stimulates the liver to make compounds that predispose you to having clots. And that's clearly the worst complication associated with hormonal contraception. As opposed to when you take things orally, when you swallow something, everything that you eat gets absorbed through your gut, and then it goes to your liver before it goes to your brain and your ovaries or any place else in your body. This is true of all medications. And so your liver sees that it gets that, the high concentrations coming from your gut, and it metabolizes, it breaks them down, but it's exposed to a level that's much higher than what your brain sees. And so you have to give enough hormone orally so that your brain can see it, but your liver sees a lot more. And as a result, oral medications, oral hormones are associated with higher concentrations of blood clotting factors because the liver responds to that high concentration it's seeing from the gut. Now, that's not to say when you give it through the skin or the vagina, you still can have those complications. It's just that you get less exposure when it's given through the skin or through the vagina. So that's
we're going to talk
about spectrum. Oh, and then there's IUDs that have released progestins. There's IUDs that have copper. And so that's a whole nother but that's those hormonal levels that even within the IUD are typically low enough that they don't turn off the ovary. You may not get your period because of the local effects to the uterus, but they don't turn off your ovary. So you can still have hormonal changes monthly without having menstrual periods monthly with the progestin IUD.
Thank you for that whirlwind overview. We're going to come back to some of those risks a little bit later. Maybe just to switch gears a bit, Dr. Pavlovich, how common is it that people come to you on these medications and want to talk about them relative to migraine?
Frequent, very frequent, because we said, we said the hormonal fluctuation affects migraine, right? That's where we started off as. And we also know one is that these fluctuations make migraine treatment in a way, in those who have very, periods that are predictable, they actually make treatment somewhat predictable. And though menstruation is a trigger for migraine occurrence in about 2/3 of women who have migraine, like a reliable trigger, and they tend to frequently have migraine in association with menstruation, at least 2 out of 3 periods. That's what we know on a population level when we look at majority of women. Of course, there's variability among individual women. So though that can be very frustrating, on one hand, it also creates this opportunity for treatment because it's somewhat predictable in those who have predictable periods. And as Dr. Stika said, we know so much about hormones that we have this opportunity to treat. The question is, though, again, it gets back to the interdisciplinary approach in this case, where a neurologist and a gynecologist often have to work in tandem for optimal treatment with hormonal manipulation of migraine, which has definitely been proven. There are many studies supporting hormonal treatment of migraine. It's just that we'll talk later a little more about the risks associated. Medicine always aims at first mitigating risk. Right. So this is the first do no harm is the order by which we all operate. And that can sometimes be frustrating for patients to understand why a neurologist is not prescribing contraception or various hormonal treatments, though we understand it, because there are many factors that come in. And Dr. Stika's level of expertise really requires gynecological specific training rather than a neurological training. But to answer your question, Dr. Sando, yes, this is very common. And, we before talked about, fluctuation of hormones and how this correlation with hormonal fluctuation has been known for centuries. But also what have we known more lately in terms of specific hormones, particularly estrogen and progesterone that Dr. Stika spoke about. So if I may get a little bit into pathophysiology of migraine, and how we believe that migraine is though we can use both estrogen and progesterone for treatment, first of all, as birth control and also for regulation of migraine, we primarily believe that it's estrogen withdrawal, the drop in fluctuation of estrogen, that regulates migraine. And the first experiments that showed us that came from in the 1970s, were done in UK. And then there were many other studies to support this. But fundamentally, most of the data related to migraine is really based in estrogen. And though it's very likely that progesterone also plays a role, estrogen is the primary hormone that we believe causes kind of migraine occurrence and whose fluctuations are really important.
Mm-hmm. Absolutely. And I recognize that we're getting into an area where I really want to hear answers from both of you to all of my questions. So we'll try to make sure that we have time for both of your expertise, because I'm really enjoying this hormone story and migraine story interplaying. Maybe just, Dr. Stika, did you want to add something there before?
Oh, I was just going to say, in terms of working together with a neurologist for years and years, I worked in a complex contraception clinic where I actually had a neurologist with me, and we would see specifically patients with epilepsy, patients with menstrual migraine, and we would use we would help people select the best contraception for them, but we would actually also use contraceptive hormones to help reduce the frequency of the seizures or the frequency of their headache.
And maybe we can talk about this next instead of saving it for later. There's no reason to not talk about this now. So how do you approach thinking about what hormones to use if you're trying to target something like menstrually related migraine?
So menstrual-related migraines occur, as we've all been saying, when estrogen levels fall. And the simple way to use hormones is to not let them fall. And so you want to turn off the ovaries by giving them a constant level of, you want to stop ovulation. So all of the different ways that I've talked about with hormonal contraception will stop ovulation. So you can use any one of them. But like with the classic way of giving birth control pills, where you have it for 21 days or 24 days on and then, 4 to 7 days off, you've got that window where you've gone off of them. And so, the cyclic method of giving birth control pills actually gives you falls in estrogen. I mean, they're, pharmacological falls in estrogen. It's not coming from your ovary, but your brain sees it just the same. So you don't want to use a kind of contraception where you have that break, that placebo break or that withdrawal break. So you can either give, for people who are absolutely wedded to birth control pills, I would pick a very, very low dose estrogen pill and you just give it to them and you just have them take it continuously. You don't have to, there's no reason why you have to have a period. The only reason why birth control pills were designed to have periods is because, the men who made them thought women liked having periods or that in some way it made them feel normal. Well, you don't need periods. And so you can just give birth control pills continuously. The only issue is that sometimes you get breakthrough bleeding and it's random and it's irregular. It's not typically ovulatory. It's just a destabilization of the uterine lining that's bleeding. And that's no fun. So what you tell people then is, okay, stop them for a couple of days and then just get right back on. And that's usually enough. They bleed a little bit more. The lining stabilizes and you're fine. I personally liked using the vaginal approach to hormone delivery because you're able to, it gives very low levels of estrogen and they're constant. And you have the choice now of 2 different rings, but essentially what you want to do is you put the ring in, you take it out, and you put a new one back in. So for the Anovera one, the one that can last a year, you don't ever have to take it out. You just leave it there. The only time you would take it out is just if you got, a spotting that was just too much of a nuisance. You need to take it out for a few days and put it back in. But that's essentially what you want to do. To me, those are the easiest and the best ways to deliver, hormones continuously. The Depo-Provera or the progestin implant, the etonogestrel implant, the Nexplanon, both also turn off the ovaries constantly. And that's another approach without using estrogen that drops your estrogen levels down relatively low and fairly stably. So you have different ways depending upon, people's choice, what works for them. And you also then have to play in like what other hormones, what other medications they're taking, because some can interact with that. What are their risk factors for all sorts of other things? But essentially what you want to do is turn off the estrogen that the ovary makes. And if you're giving them extra estrogen, make it constant and not let it change.
And I often get asked about IUDs. What do you tell people about IUDs with respect to these hormone manipulation in migraine?
Sometimes they work. Sometimes they absolutely work. I have used lots and lots of IUDs, progestin releasing IUDs. Long-acting reversible contraception is really the way to go in terms of contraception. The problem is, even with the higher dose progestins in the IUD, because you have a whole spectrum, you have like 4 different IUDs and they have 3 different concentrations of levonorgestrel that they release. It doesn't necessarily guarantee turning off the ovaries. You don't get pregnant because the sperm can't get into the uterus because of the cervical mucus is too thick. It can't implant because the lining is so inhospitable that, a fertilized egg just doesn't find a place that works. Or the sperm get killed when they're trying to pass through the uterine lining. So they're definitely effective at preventing pregnancy, extremely effective. They're just not so good at turning off ovulation. And so for menstrual migraines, you could still sporadically, in an unpredictable way, Dr. Pavlovic, like you were talking about, you can still have erratic, fluctuations in estrogen hormones that can precipitate migraine with the progestin IUD.
Mm-hmm. And Dr. Pavlich, what do you tell your patients to expect with hormonal contraceptives and migraine?
Well, that they can use, first of all, this is hormonal contraception, especially exogenous estrogen containing hormonal contraception, is currently indicated only for those patients who don't have migraine with aura, who don't have aura as part of their migraine.
Exactly.
So this is an important part, and this is when I earlier alluded to why this is sometimes seems very complex to the patients. To the patients, it may seem overly complex, the kind of academic rigor we go through in these decisions, but they are for very good reasons and because of this associated risk with increased cardiovascular events and particularly stroke. And the fact is that if stroke is a migraine risk, that is stroke is more likely to happen in women who have migraine than in women who do not have migraine. And particularly in women who have migraine with aura, stroke is even more likely to happen. And if those women smoke and actually take exogenous estrogen containing pills or any other form of exogenous estrogens, but particularly tablets, because Dr. Stika told us the liver sees a lot of it, that even further increases the risk of stroke. Now, not to scare everyone, that risk of stroke is relatively low in the absolute numbers. But still, if it happens to you or your loved one or your patient, that is enough. So therefore, the guidelines of the the World Health Organization and ACOG, the American College of Obstetricians and Gynecologists, have been very cautious about use of estrogen in migraine at all, and specifically counsel against no use of estrogen-containing compounds in migraine with aura. I see Dr. Stika nodding her head. Now, the International Headache Society, American Headache Society, approach a somewhat more relaxed attitude towards it, saying, because this happens clinically often, is that women have already been on contraception of some sort. This happens in my clinical practice, and they have done fine. And they've been maybe on it for 10 years. They started in their 20s, now they're 32, and they have had headaches, migraine-like headaches for years, but they were never diagnosed. And now, let's say at age 32, they present to a neurologist and are diagnosed with migraine with aura. And it can be incredibly frustrating for a woman who has been on, oral contraceptives and this is the caveat, is that these oral contraceptives are currently very low dose containing of exogenous estrogens, while the guidelines, these very strict guidelines, that suggest that they specifically say do not use them in migraine with aura and don't use them in migraine over age 35, even without aura, come from an era, as you both know very well, when much higher doses of estrogens were used. And Dr. Sika said, a lot of oral estrogen was delivered for the brain to see anything. And so we don't have, the issue here is that we are lacking updated studies. We are all working on this, but this is hard to come by, and it hasn't materialized yet. But I think the point for the women listening to this is that oftentimes working closely, this is why working closely with a neurologist and a gynecologist, like Dr. Sika was saying in her practice, is important, because in migraine, if one benefits from treatment with contraception, with both hormones, estrogen or progesterone or combination, then there may be a benefit versus risk overall benefit that would still, where physicians as a team, and the patient will decide to actually stay on this particular contraception, though the guidelines do not advise it. So this does occur in my practice, and it's really something that requires a lot of care and conversations with the patient and a lot of information to be exchanged.
And in my experience, because I feel so comfortable with non-estrogen forms of contraception, I've been probably a little bit more strict or rigid. I mean, I follow those guidelines because I think I'm able to manage and work with patients with the progestin-only options. And the progestin-only options have gotten a lot better.
Yes. Absolutely. But it requires work. It requires fine tuning. I think that's the overall message. Oftentimes patients don't get results with the first IUD or something. This requires fine tuning. And as you said, there's so many options nowadays with first of all, better delivery systems and lower overall absolute amount of hormones that actually can work quite well. And, and they don't have to be used in isolation, that they obviously should be combined with other migraine treatments, preventive and acute treatments. And so it's truly a joint approach of one and the other.
Mm-hmm.
And maybe before we talk a little bit about those non-hormone strategies, I just also want to make a comment that I think it's relatively common for the word aura to be used in different ways by different people. And so the word aura means something very specific to a headache neurologist. It means things that meet our criteria for aura, whereas sometimes people use the word aura to mean other things that we don't think carry a risk of stroke. So people may use that word to mean they have brain fog during an attack, or they have some other symptoms that are not in keeping with what would really be an aura. So this is an important one to talk to your doctor in detail about, to figure out if you really do or don't have aura, to help guide these decisions. And the American Migraine Foundation has some good tools for finding a doctor to help you do that on our website if you are looking for somebody to help guide that journey. And so maybe just in the last couple of minutes before we take questions, Dr. Pavlovich, can you tell us a bit about those non-hormone strategies for treating things like menstrually related migraine?
Sure. So menstrually related migraine, right, which we discuss now, hormonal, is defined as attacks that occur about 2 days prior to the onset of migraine and the first 3 days of migraine. That is what the literature tells us. Now, in an individual woman, these attacks may start, it's the attacks that occur in relation to your period. Typically, they will start before the onset of the period. And this gets into the ability to predict in those, or to at least anticipate, if not completely predict. And so it is important. One of the first things that we ask patients to do is please keep a headache diary, a migraine diary, in relation to the occurrence of your period and in relation to the rest of your life. So I like to see a diary that is, and this sounds very simplistic, but it's so informative. So on a typical kind of calendar diary where you can see the days of the week and you can see regular activities, if somebody has shift work or not shift work or regular, whatever it is, to see where do migraine attacks occur in relation to one's life and days of the week, and in relation to menstruation specifically, to your period. And typically when we get diaries, ideal is to have at least 3 months of diary, but 1 month, anything will help, is better than nothing. So, just try to keep it as good as possible, and without it being like an onerous, stressful thing. And when we look at these diaries, oftentimes a very clear pattern emerges. And the pattern is a day or two prior to the onset of menstruation, prior to bleeding, a headache starts, and then it continues. So in those patients who have very debilitating, and these attacks tend to be, we know from literature, we know from our patients, tend to be particularly burdensome. They tend to be more severe, longer lasting, and harder to treat than other migraines that don't happen in relation to the period, right? And we call them interchangeably perimenstrual attacks. The diagnosis is menstrually related migraine. There is also a diagnosis of pure menstrual migraine, which means that women don't get attacks at other times. Women who have menstrually related migraine will get attacks in those 2 days prior to onset of bleeding and 3 days of bleeding, and women who have only attacks at that time will have the diagnosis of pure menstrual migraine. In women who have pure menstrual migraine, meaning only attacks around menstruation, we can really use strategies around mini prevention and predictable mini prevention, and just treat those 5 days or that week. Start a few days prior to onset of the headache, especially diaries being very helpful here. And the typical treatments that are used for treatment of migraine work in this setting. So that there've been studies done with NSAIDs, meaning, common drugs like ibuprofen and naproxen, on the market, typically seen as Advil and Aleve. And in high doses taken twice a day, steadily over 5 to 7 days, they've been shown to work. Another drug class of triptans has been shown to work, especially, and because we generally want twice daily, standing treatment, because this is the time when we know that the headache is very likely to occur, and when it starts, it's very hard to treat. So it's a prevention state, and taking it twice daily. So for triptans, we want to take longer acting triptans, like not shorter acting. For example, sumatriptan is a short acting triptan, meaning it works for a shorter period of time. Naratriptan is a type of a triptan that works for a longer period of time. So typically we will prescribe a longer acting triptan, like a naratriptan, twice daily for about 5 days. In those patients, and then the current drug class of gepants, such as rimegepant, tobrogepant, have also shown benefit in treatment of perimenstrual, those menstrually related migraine attacks, as similar to the treatment of other non-perimenstrual attacks. And the data and work on that is emerging at this time. But from experience and from what is available, we can see that they work for these types of attacks. Now, for women who have menstrually related migraine, meaning they experience really bad attacks during that time, during the -2 to +3, but also at other times, they're really good candidates for preventive treatment of migraine. And we utilize the same type of prevention that we do for all migraine. We don't distinguish. In fact, there are currently no medications on the market at all that have a specific indication for menstrually related migraine. All the medications that we have are indicated for migraine, episodic migraine or chronic migraine, but there is no specific treatment for menstrually related migraine. And that is to say that most medications that we currently use in women who have menstrually related migraine. And not only medications, behavioral therapies, lifestyle modification therapies, and neurostimulation therapies work as well, because they overall decrease the threshold of pain and threshold of migraine.
Thank you. And I recognize that this topic could be a webinar, a very long one all by itself. So we've shortchanged it a little bit, which I apologize about. We're going to move over into the question portion of tonight. And I do just want to start by saying we've got tons of questions. We're going to do our best to answer as many as we can. But we're going to try to answer the ones that are closely related to tonight. I know there are a lot of questions about things like menopause, which is, of course, of lots of relevance from the hormonal perspective, but we will be having that webinar on menopause in March. And anyone who wants to register for that, the link should go out sometime a week or two in advance, similarly to what tonight's did. So please come and submit those questions for that webinar. In the meantime, maybe a slightly different question. Is there a known relationship between PCOS, polycystic ovarian syndrome, and migraine?
You want to respond to that?
Well, there have been studies. Yes, there is. The simple answer is yes, there is. There have been small studies on PCOS and migraine, showing that women with PCOS, there's a comorbidity. That is that women who have migraine have PCOS more often than women who don't have migraine, and women who have PCOS have migraine more often. And that is not surprising, right? Because PCOS has even and Dr. Stika can elaborate on this, the dysregulation of the hormonal milieu and of what happens with hormones is even more accentuated in PCOS, simply put, than in a regularly menstruating woman who doesn't have PCOS. And therefore, those fluctuations are likely to increase the occurrence and existence of migraine.
I'm not sure I need to respond to that. I mean, because that's a whole nother hormonal tangent. And I think I would prefer to talk about additional questions if that's okay. But
absolutely,
somebody wants me to talk about hormonally what happens with PCOS.
No, I think it was interesting to think of as one of those, like Dr. Pavlovich said, conditions in which hormones are fluctuating a lot, and so it's likely to be quite impactful for migraine. So here's another question. Is it possible for long-term hormonal contraceptive use to cause migraine?
Do you have an answer to that? I mean, those are people you would see.
Well, so we know that the answer I don't have, the part that I don't have a clear answer to is long-term contraceptive use. So we don't see people who have been. We have no data that answers the question, does it, if somebody has been on 5 years of contraception or 10 years of contraception, does being on 10 years of contraception increase risk of migraine over 5 years of contraception? I don't believe that there's any data for that. And based on what we know about how migraine works and how hormonal fluctuations, I don't see why there would be why that would be something we should suspect may be possible. Now, what does happen is that when women are started on contraception, especially on exogenous estrogens, and then when the exogenous estrogen starts to fall, especially on high dose exogenous estrogens, that may precipitate a migraine occurrence, and generally happens early on in the process within, second or third month. And the other part that can happen, especially with introduction of high dose of estrogen, is the first, in a woman who has migraine or doesn't have a migraine, occurrence of an aura, a new onset of aura. And that is a situation we do not like, so to say. And that is a situation where we want to stop, in general, contraception.
There's another scenario where it might happen, which is not everybody who has migraine gets it with their first menstrual period.
True.
And if hormonal contraception, for whatever reason, whether it's to control your menstrual periods or for contraceptive purposes, are started early enough where somebody has yet to manifest symptoms of migraine, and they're on a contraception that's relatively stable, that doesn't by itself on off predisposed to fluctuations in estrogen, you could be a migraineur and not know it. In other words,
you could mask it, right?
You could mask it, exactly. And then when you ultimately stop whatever hormonal contraceptive you're using and your own cycles recur, you could then begin to manifest and show. It could be unmasked, and you could show and think, well, did I get it because I was on hormones for that length of time? No, you're unmasking a situation you always had. It's just that the hormonal contraception that you were having covered it up.
We do see that in women who have, let's say, again, the scenario started, started contraception with both estrogen and progesterone in their 20s, has been on it for about a decade, and now in her 30s, she's planning, conception planning and wants to, get pregnant. And so comes off the birth control, and then that starts a whole cycle of migraine that can be challenging to treat.
Right.
I think this speaks to one of the earlier points that was made of, if you have migraine, this is something you're born susceptible to. And then some of these changes can build up over life and increase the likelihood of you expressing it in a greater or lesser form. And maybe just to touch on this stroke risk and aura, there's a question about please helping us understand what actually is the definition of an aura. Dr. Pavlich, could you maybe just very quickly tell us what we actually think of as aura?
Well, so aura, for neurologists, we know that aura actually has a correlate of what happens in the brain, and happens kind of in the highest order of the brain structure, which is called cortex. Now, this is a neurologist explaining, like it's, how can you simplify it? But it's important because the part to understand what happens is this wave, this neuronal wave, literally, it's a wave of electrical stimulation travels across that part of the brain. In the back of the brain, where it's most likely to activate, is where we process vision. And in other parts of the brain, as it travels, we process sensory, feeling numbness, tingling, motor movement of arms, legs, and so on. For some reason, it's most likely to activate in that portion, occipital region, where visual symptoms are processed. So typically an aura, and so why I'm focusing on this wave is because the wave moves over the brain and that causes the occurrence of aura. So aura will have what we call both these positive phenomena. It will be not lack of visual field, like cut. It will be lights showing up, various zigzag lines, and because it's a wave, it's moving. So the phenomena that one is experiencing will actually be moving through the visual field. I always say, simply put, an aura should have a story to it. It shouldn't be like, I saw a little flicker here. There should be a storytelling part. And this is sometimes very hard to pinpoint, but there are phenomena happening because of this traveling wave of neuronal excitation. Now, though visual is most common, and there should be lights and zigzag lines and changes in kind of visual perception. It can also have a sensory component if it hits a sensory part of the brain. So numbness and tingling can happen in one limb, face, at various regions, or even motor deficit, meaning becoming weak in one area. And sometimes can be very disturbing to patients, as you know, is if the aura is speech related, right? And there's a deficit or challenge of speech. Now, what is very important about aura versus stroke, where things get scary, is that aura should pass, and aura should have an evolving. It shouldn't be just, this part here got numb, stayed numb, and that's how it's been. It should be kind of like, oh, I felt tingling and numbness coming up and down my hand. It started kind of relatively suddenly, lasted about 5 minutes to an hour, not 20 hours. And then it went away and I'm back to my normal. That is a clinical description of aura.
Thank you. I think that's really helpful. And I think this is one of those other things that's very helpful for people to keep a diary of and really write down in time what it is that they're seeing or feeling to help with that diagnosis. We're close to time, but I think maybe, go ahead, Dr. Sika.
One thing, just in terms of how that comes back to blood clotting, that the aura phenomenon is oftentimes associated with blood vessels getting smaller and tighter. Or what we call vasoconstriction, that instead of a blood vessel being like this, it's squeezed down. And because the blood vessels are tighter, that makes them more prone, to clotting, to more irritation in them, or that inflammation associated with that. And so that's why aura is more concerning, because we know when those blood vessels are tinier, they're more likely to respond to and be adversely affected by potential small clots.
But one thing, just to be reassuring, I recognize this sounds scary, is that we don't think that auras are damaging your brain when you have them in general. So it's not that you are having
there's no evidence to suggest that, yes.
Yep. So very fast question for you, Dr. Sika, before we finish. Is there benefit to doing hormonal testing for treating menstrual migraine?
What would you be testing? That's my question. Can the person put that in because what you're looking for, as Dr. Pavlovic talked about, the migraine calendar will show you whether you're getting flares, whether it's pure migraine or pure menstrual migraine or menstrually related, where you get them at other times, but you get flares during your menstrual cycle. And we know that's because there's falls in estrogen at that point. And so doing hormonal tests to see what's your level of FSH or what's your level of estradiol isn't going to change the picture. somebody might make more estrogen, a little bit more with their menstrual cycles than somebody else, but you're still going to have that fall, and you still need to treat it in the same way. So I don't think testing for hormonal levels is going to help you give you any better insight in terms of how to manage it, or how to diagnose it or manage it.
I agree. It's really clinical picture, and the more information you can bring to your doctor, as we said, in relation to the rest of your life and things like your period, will really be most informative.
One more thing just about PCOS that you were talking about in terms of migraines. People with PCOS who don't ovulate regularly oftentimes have a hard time getting pregnant.
Yes.
They then go to an infertility, a reproductive endocrinologist to have them help, a fertility specialist. And the problem with that is when you stimulate the ovaries to produce eggs to get pregnant, you can sometimes get much higher levels of estrogen with your cycle. In other words, if a normal menstrual cycle, your estradiol levels go up to 200 picograms, with a stimulated cycle, they can go to 1,000, sometimes scarily though 2,000 picograms, and then those fall. And so the problem then becomes people with menstrually related or pure menstrual migraines can have even more migraine attacks when they're trying to get pregnant.
And this was not a plant, but that is the subject of our next webinar in February. We're going to talk all about this. So thank you, Dr. Sika. That was excellent. And we're at time. So I'm going to say thank you so much to everybody for joining and for all of the great and broad-ranging questions. Again, please come to the next webinars in our series as well. Thank you so much, Dr. Sika and Pavlovich, for the fascinating discussion. I really enjoyed it. And thank you again, everyone, for joining us. Have a great evening.
Thank you.